resource centers made up of 14 telehealth resource centers who are federally funded to provide technical assistance to programs who are interested in starting telehealth programs. There are 12 regional resource centers that cover specific states and 2 national centers, one on technology and one on policy. I represent the Policy Resource Center, the Center for Connected Health Policy, which is based in Sacramento. Next slide. A few housekeeping items for your information. First off, today's webinar will be recorded, so please keep that in mind. It will be posted later for anyone who wishes to review the webinar again or perhaps you're unable to attend today. We ask that your phone or computer microphone also be muted. Time for questions and answer will be reserved at the end. The Q&A function is strictly text and chatting format, so there will be a box, a little option, a button at the bottom of your screen. It's typically there. It might be at the top, but it's typically at the bottom, where you can type in a question for the presenters that will be answered towards the end of the presentations. We also ask at the end that you fill out a post-webinar survey and that you provide us with feedback on what you thought of this particular series. Next option. This is the first of a 3-part series directly focused in on FQHCs and community health centers. The first one today is on chronic care management. The upcoming topics will be on substance use disorder and mental and behavioral health. Those dates will be announced soon, but they will be approximately about 2 months apart from each other. We also ask that if you're interested in more information about the webinar series or on what the National Consortium does, please also subscribe to the NCTRC newsletter. Next slide. Today's speakers, and you are in for a treat because we have some great speakers today. They are Kathy Wibberley. She is Director of the Mid-Atlantic Telehealth Resource Center based out of Virginia. Howard Chapman, Director of Program Development at Tri-Area Community Health, also in Virginia. And Richard Albrecht, Director of Telehealth Network, Health Network Holdings in Wallingford, Connecticut. So I will not take up any more time and hand this over to our first presenter, Kathy Wibberley.
Okay, great, thanks, Ray. If you can hit the next, you can actually go to the next slide after this. So what I'm going to do is a really quick overview of what is chronic care management, just from the context of Medicare. Because we know that the different codes for Medicaid and private payers are dependent on state, and we don't have time to go state by state for each of this. But just a little bit of a caveat around the whole Medicare piece. For the most part, our understanding has been just from history is that where Medicare has made changes, typically the trend is that Medicaid and private payers will tend to follow. And so Medicare is often seen as the lead in kind of defining what is reimbursable or not. So just kind of keep that within the context of what we are sharing today. So in general, and I know that most of you are more than familiar with this, chronic care management is really care coordination that's outside of the regular office visit for patients with multiple 2 or more chronic conditions. And so this is just kind of preaching to the choir right now. So the next slide. Just to give you the context of this, for chronic care management, the requirements that Medicare has are on the patient side. The patient has to have 2 or more chronic conditions. They have to be a serious health risk or at risk of death. They must consent to the services, and they may have a copay for the services. So on the provider end, you have to use a certified EHR technology. It has to be 20 minutes per patient per month or more. You have to document the time spent per patient. There's monthly reports and summary of your chronic care management services. It has to be 24/7 access to care management services, comprehensive patient-centered care plan developed, care plans available 24/7 to your entire staff, and shared with EMR and other providers. So that's kind of the big picture context of chronic care management. So next slide. So these are the CPT codes that have been made available to FQHCs for chronic care management as well as for complex chronic care management. I'm not going to go through each of them, but just to give you the context for when we add telehealth to this piece. So next slide. So right now, if you are doing chronic care management for your patients, these are the types of non-face-to-face activities that you are probably documenting. So everything from monthly clinical chart reviews, phone calls to caregivers or their family members, phone calls with other providers or facility, lab orders, and all of those things that you do that are non-face-to-face activities with a patient. So next slide. So what we're going to focus on today is the role of telehealth within this context of chronic care management. If you have these patients who you're already providing these services or about to provide this whole package of services to, where does telehealth fit in? So the first thing that I want to mention is this chronic care remote physiologic monitoring. These codes began January of this year. Our understanding is, and here's one little bit of a caveat, our understanding is that this is applicable to F2HCs. We've not heard otherwise, but we've also not heard confirmation of anything other than, you know, the people that we have talked to who are involved in this and have been engaged in the advocacy of this have said, you know, we believe that this is available to F2HCs, but we don't see anything in writing yet. So just that one little bit of caveat. So there's CPT code 99453, which is remote monitoring of physiologic parameters. CPT code 99454, which is remote monitoring, again, of parameters with devices or supplies each 30 days. And then the 99457, which is remote physiologic monitoring treatment management services, 20 minutes more of reviewing kind of the patient's time and then any interactive communication with the patient. And the nice thing about this part is that it specifically talks about other staff. It doesn't have to be the clinician doing this monitoring. Now, what happened in the language is that CMS has already made a technical correction in terms of the supervision level, and they changed it to incident to billing. But unfortunately, incident to billing means direct supervision. And so they are in the process of doing another technical correction that will allow general supervision, which then means that the practitioner and the clinical staff do not have to be co-located at the time that this service is taking place. So that's kind of where things are at. This is brand new, and there's still a lot of guidance that needs to come out for this, but we do have F2HCs who are doing the traditional remote patient monitoring of this. We're not going to be hearing a lot about that in the presenters today, but just kind of give you the context of what is available. So next slide. So there's another piece that is very, very relevant to what you all are doing, and we know that these are allowable for F2HCs, and it has been put in writing. So there are two things that came into play also January 2019, and it's called communication technology-based services. These do not undergo the geographic restrictions or the restrictions on provider type, so F2HCs are allowed to do this. The geographic restrictions that CMS has for other telehealth services, CMS has really removed this set of stuff out of their definition of telehealth into communication technology-based services. And so there's brief communication technology-based services, or the virtual check-in, and there's remote evaluation of pre-recorded patient information, which is kind of the store and forward piece. So on the next slide, I'm going to go into a little bit more detail on what's required. So when these services are billed by an F2HC, you are actually using G0071, and it can be done either alone or with other payable services. So the parameters around using the G0071 are, it's not originating from a related E&M service provided within the previous 7 days. It's not leading to an EMN service or procedure within the next 24 hours or soonest available appointment. It involves at least 5 minutes of medical discussion or remote evaluation by an F2HC practitioner. It's only for established patients who have had a billable visit within the previous year, and that's really to avoid the kind of for-profit companies who are coming in and doing the, you know, pay $40 for your e-consult or e-visit. This is really for established patients and tied to a medical home. Must be initiated by the patient. So it has to be the patient who's saying, you know, giving you a call or connecting to you by an audio video system, or sending a picture or video for evaluation. The F2HC practitioner may respond by phone, audio, video, secure text messaging, email, patient portal. So the practitioner has a lot of latitude on how they respond to that patient query. The service must have verbal consent of the patient, and the patient will be responsible for any co-insurance related to the service. At this time, CMS has put no limitations on the frequency. So your patient could, send you a phone message and say, I need to talk to someone today, and then tomorrow they may do the same thing again, or they can call you in the morning and then call you in the afternoon. There's no limit at this point on how often this can take place. So next slide. So what I did is, so as to give more time to our presenters, is giving you kind of the links to the actual CMS fact sheets on these services and what's allowable and what's not. And what will be missing is the piece about the remote patient monitoring piece, because we have not seen any strong guidance on that yet, but hopefully when that comes out, we can get that out to y'all. So that's all I have. The next slide will just give you my contact information in case you have questions for me directly. And I will then cut to our next presenter.
All right, well, thanks, Kathy. And John, or Ray, we'll go to the next slide. A little about Tri-Area Community Health. We're a small FQHC, 3 sites, actually in Laurel Fork, in Carroll County, Floyd, the town of Floyd in Floyd County, Ferrum down in Franklin County, but we serve 4 counties here in rural Southwest Virginia, Carroll, Floyd, Franklin, and Patrick counties. And we're in the Blue Ridge Mountains, which typically is some of the higher elevations here in Virginia. We do operate 2 full-service pharmacies at Floyd and or at the Ferrum and Laurel Fork sites. We have integrated behavioral health with our primary care. We serve about 10,000 patients a year with about 35,000 patient visits, around 95 total employees with about 18 medical and behavioral health providers. And Tri-Area is recognized as an NCQA Level 3 patient-centered medical home. We are in part of the economically depressed Appalachian region, so we do qualify for some ARC funding as well. Next slide. Policies and issues affecting telehealth. Most of the policies that drive telehealth are on state level basis. So I would encourage you to know what those state policies and regulations are. A lot of that's around reimbursement, and so again, it'll vary from state to state. Virginia's been pretty progressive at trying to make certain that telehealth's covered. Our policies, keep up to where we actually are getting reimbursed for a lot of things. But Tri-Area started about 18 years ago, and typically the equipment's set for a long time, very used, very little. And in 2011, they really started back up. We had to actually replace all of our units. They were the old analog systems. I'd be upgraded to the new digital systems. We actually put systems in all 3 of our locations. We started with a link to the University of Virginia, which provides us access to 24 specialty services. As a state-supported medical school, UVA actually has a sliding fee or an indigent program that they allow our patients to be seen on a sliding fee basis. So again, it's been a great benefit for a lot of our patients that really don't have access here locally. When we first started, there was not a lot of regulations and things, so we actually were able to do incident 2 reporting, so we got paid for doing the physical and things on our site, and UVA got paid for their specialty consults and things on their site. But in 2005 or 2006, CMS just footnoted that particular code and said we no longer recognize that code. Again, the parity law in Virginia, next slide. Parity law in Virginia mandates that equivalent coverage for telehealth visit, same as an in-person visit. So we get paid by most private carriers, but also our Medicaid, anything that has a state employee health benefit, we're covered under that. Medicare is still the one that we have issues with, primarily because of the restriction of not being able to serve as a distant site. State mandates reimbursement on all Medicaid services provided by the live video and audio connection that you can do. They do reimburse for other telehealth applications, although the rate may be a little different in some of those. And Tri-Area is paid for telemedicine even as a distance site by Medicaid and most of our commercial insurance carriers. Next slide. Some of the issues we face, again, poor connectivity out here in rural Southwest Virginia, not a lot of really Wi-Fi signals, really low broadband with most people are still using like a dial-up connection in their homes and things, which severely limits what you can do. Currently, we're about 50 megabits per second at our Laurel Fork site, about 20 megabits per second at the other two sites in our corporate office. And that's a great improvement from what it was 2 years ago. 2 years ago, it was 10 megabits per second at our Laurel Fork site, 6 at the Floyd site, and 3 megabits per second at our Ferrum and corporate office. So again, it doesn't take much to exceed that. And they're usually competing with your EMR, your practice management system, the emails, and all the internet services and things you have are competing for that bandwidth. Next slide. The human and technology resources required for telehealth. Again, the camera, the monitor, the cart setup probably now is under $12,000. 18 years ago, that probably cost you around $75,000 for that initial setup. You need good connectivity, at least 25 megabits per second or greater. You need a secure network to maintain your HIPAA requirements. Trained staff. There are a couple of certification programs. I know we've had 3 or 4 people go through the STAR program, which I think was modeled after what they were using in Alaska for a certification process for using the equipment and setting up on the originating site end. And UVA actually offers a certification program more as an online type program. So again, there are several different processes you can do that. I think one of the important things too is you have to have a good provider champion, somebody that knows the benefits and can see the benefits behind using telemedicine, telehealth to link to the specialist and the other things that they don't have pretty much on site. And you need support from senior management. If you don't have somebody that's a decision maker that can actually commit resources and time, it is pretty hard to get a telehealth program off the ground. Next slide. I think the benefits to community health centers. One, most of the physicians are trained in an area where they have everything right at their fingertips. And so telehealth actually removes a lot of the rural isolation for the physicians. It makes it easier for them to recruit and retain those physicians in a rural area like this. It improves compliance with patient-centered medical home. It improves the patient's access to specialty care. We're short in our area on primary care providers, and for one reason we're funded as a community health center. But that for the specialty care providers, it's a much different situation, and there are a lot fewer in these rural areas than you get in some of the bigger communities and cities. It improves the patient compliance with treatment plans. It improves the care coordination you need as a patient-centered medical home. Next slide. Some types of telemedicine, telehealth that we use here, the synchronous or the live and real-time video and audio link, the access to the 24 specialties through UVA. UVA having a sliding fee program for our Virginia uninsured patients makes that a really seamless process to get them into care. Our provider and staff CME, actually our providers can do grand rounds with folks at UVA if they're set up and signed up to do that. We have patient education, certified diabetes education classes. I know one of the local hospitals here was charging $300 for a 10-week session or $30 a session. A patient that can't afford to buy their medications really don't see the benefit behind that education piece. Our diabetes quality improvement plan, which we want to talk about a little later here, the asynchronous or store and forward type technology. we have a statewide contract through our Virginia Primary Care Association or Virginia Community Healthcare Association for X-ray interpretive services through UVA. They're digitally transferred electronically. We get the results back the next day, and we can even get stat readings for emergencies that we need. We have a digital retinopathy camera for our diabetic patients at all 3 of our sites. When we first started doing those diabetic retinopathy screenings, about 40% of our patients said that's the first time they've ever had that screening. And again, I think it's just due to the fact the travel and distance that they have to do in the rural areas. The director for the Department of Ophthalmology at UVA actually went through an FDA approval to get that to where he could actually do those on an iPad or on his smartphone. And his goal was to try to get those down to where he could do them within 20 minutes. So while the patient was still in the office, we could actually schedule an appointment for a follow-up, either with a local provider or through UVA as the default. Next slide. These are the 24 specialty services that UVA offers. I won't take time to go through all those, but again, they should be in the slide deck if you guys want to go through them. Next slide. Our diabetes quality improvement program, again, it focuses on the uncontrolled diabetic patients, those with a hemoglobin A1C of 8 or higher. The endocrinologist follows the patient for 6 months with telemedicine, and he actually does some on-site visits here at Tri-Area. It's coupled with the certified diabetes education classes and the digital, their diabetic retinopathy screenings. We use a home monitoring device to measure the blood glucose, the dietary intake, the physical activity, and other things that he graphs and moves up to a secure cloud. We upload, it's not really the device we wanted to use. The one we wanted to use was a real-time process, but it required a good deal of Wi-Fi bandwidth and stuff. Just doesn't exist here. So the device we use actually sends a low frequency signal up to a smartphone, and then as they put it in the phone in their pocket or in their purse, and they hit where a signal tower has a signal, it'll upload it at that time. So it's really not real time, but it's the best we can do out there right now. And it grabs that data and can be accessed by the endocrinologist, by the patient, by our Tri-Area providers, nurses, and case managers through a secured password clearance. Next slide. This is just a slide from within the first 2 years of Dr. Santon's work. And again, if you'll notice, the slide on the left, actually some of those up to like 11 and reduced to below a 6. A lot of them in that 10 to 12 range that are reduced down to 8 or below. And on average, the patients that he's bringing in are at about a 9.9 on their hemoglobin A1C. And after following him for the 6 months, the ones that finished that program are down to a 7.7. So about a 2.2 reduction in their hemoglobin A1C. Next slide. The design interventions for this, it's an intense 6-month self-management component. They use the Project Echo for educational programs for our providers and staff here to better work with evaluating patients on some of the diabetes programs and things. The technology components are the use of a meal replacement, and I think he's using Nutrisystem D program, and Dr. Santon's really unique and in real ingenuity and how he obtains these. I think he got about a 2-month supply, 3 meals a day, and you know, got them to donate that. So he really does a lot of innovative things. Again, we use the cloud-based TeleCare meters. A Glucomander outpatient algorithmic insulin decision-making program. Next slide. Some of the deliverables of the program: reduction in the glucose level assessed by the hemoglobin A1C, the number of pounds and the body weight loss for the patient during this 6-month period, improvement in the knowledge regarding the diabetes and the pre and post testing questionnaire, an absolute drop in their blood pressure, and improvement in their level of exercise. Next slide. Some of the problems we've encountered with this, again, non-compliance by the number of glucose tests that the patients were required to do, non-compliance with their diet, a lack of motivation for better control, limitations of medication based on the financial situation, and undercurrent issues, which typically UTIs, URIs, and other things. And I'll tell you, one of the things our providers have said that achieve really good control while they're following Dr. Santon, that tends to go away, and the patients either revert back or slip back to their old habits. And so, you know, after the session with Dr. Santon ends. Next slide. So some of the solutions we've come up with to address some of those is the telephone calls from Dr. Santon and some of the nurses encouraging proper testing. Again, we've worked out so that the test strips and the meters are at no cost to the patient. And I'll tell you, Dr. Santon actually calls a lot of these patients directly. So I get a lot of comments back from people that are really appreciative and surprised that the physician actually took time to call them. Again, the Nutrisystem D meal replacements, 3 meals a day at no cost, and these are really small portions, so it keeps them within a dietary regimen. The behavioral health consults and the diabetes support group for family members that participate. One of the reasons we see that they don't stick to the diet is everybody else at that house is eating what you know, these folks have been used to eating all their life, and it's tempting for them to revert back on that. But the medication assistance program that we are part of, we get about a $55,000 grant from the Virginia Healthcare Foundation here. And this past year, we turned that into about $4.4 million worth of free meds at the average wholesale price. So again, able to pass those on to the patients for free. So it eliminates that barrier. And then prompt treatment by TRIARE providers for any of the undercurrent illnesses, the URIs and the UTIs. And then we're looking at actually stepping up our diabetes support group for our diabetic patients and their families and getting them involved so that, again, we can overcome that people reverting back or slipping back on some of their compliance. Next slide. I did want to thank the telehealth resource centers. You know, they're a great resource for centers and an excellent resource for centers and organizations, individuals interested in telehealth or telemedicine and other technologies. They link interested providers and health facilities to successful programs that are using telemedicine, and they provide technical assistance and arrange for testing or trainings to get programs up and running. So we work well with Kathy. She's been a great resource for us. And next slide. And that's my contact information again. And I'll turn over to the next speaker.
Thank you, Howard, and welcome to the next section in this program, where for the next 15 minutes or so, I'm going to provide a very high-level overview of how we have implemented chronic care management across 7 F2HCs here in Connecticut, and I'll share with you some of the lessons we've learned during that time. Next slide, please. So, chronic care management, and we're talking about here the G5011 or G0511 code. Chronic care management, it represents a new dimension of care for those patients who are eligible. In the F2HC environment, most of our patients, they consider healthcare as going to the doctor. So the concept of having someone outreach to them in between their routinely scheduled visits is really somewhat unique. So this slide here simply serves as a representation of one of the graphics that we developed to help educate these patients about the availability of this new benefit. Next slide, please. So our agenda today, we're going to move fairly quickly, and we're going to cover these 5 topics. But I also want to mention just for a moment why I agreed to do this program this afternoon. I've been involved with CCM. Actually, I first got involved in 2015, working for a large primary care practice where we implemented CCM in a number of our sites. And over the last 2 years, I've spent a lot of time on this program in the FQHC environment. I've come to understand that there's still a lot of misinformation and confusion around how difficult it is and what the value is and how will we ever implement that. And hopefully in the course of the next few minutes, I can help clear up some of those misconceptions. Next slide. So there's a piece of that slide that's not quite there, but anyway, I'm part of a group of 7 FQHCs here in Connecticut. We have about 195,000 patients, and I'm fortunate to work for this group. This is who comprises Health Network Holdings, 7 FQHCs, and probably have 25 distinct locations across the state. And generally speaking, this is a fairly progressive group of healthcare executives who see that telehealth and virtual care is about to become mainstream in how healthcare is delivered. And so they have invested in a strategy to improve access for instance, to specialty care access. And as you'll see in this program, chronically ill patients, giving them more resources so that outcomes are better, but using telehealth for this. Next slide, please. So let's begin with why we were even interested. And there's actually 3 answers to this question. First had to do with, next slide, please. What are the benefits for the patients? And this is fairly evident to our providers. If we could provide our patients with a current care plan and then regularly update that through structured outreach, that there would be good benefit for the patient. And next slide, please. Ultimately, that would translate into keeping us better informed in our individual centers, so better continuity of care for us in between those visits that we see those patients. And then lastly, was the fact that our centers could potentially start to receive reimbursement for a lot of the care coordination activity that we've been doing for years around these patients. These are some of the sickest patients we have in our centers, and this is the classic group, right, of those 5% who consume 50% of our resources. A lot of the work that gets done when they're not in our centers has never been compensated before, but now there was an opportunity here for us to potentially get some reimbursement for some of that work. So that checked the box on, yeah, there's probably some benefit for the health centers. And then the last answer, next slide, was this aligned with our strategic goals? So when we looked at this and we thought about the provision of more resources to patients who most need it, possibility to get a little bit more reimbursement, and then being really aligned with some of the other activities we're doing in our mission as patient-centered medical homes, we said, yes, indeed. Let's look at this a little bit further. Next slide, please. So our decision process. And we began by quantifying this. What would this mean? Next slide. And the way that we quantified the opportunity was to look first at the numbers. Now, like most FQHCs, we don't have a high percent of our patient populations who are Medicare. So we had to do the research, pull those numbers out of our system, and then make some assumptions as to whether this program would work. And so we used this little formula that we created to kind of drive to that answer. So we started on the left with the estimated number of Medicare patients that we had, and this is a real example from one of our centers. And then we made some assumptions. We assumed that 75% of those patients would have 2 or more chronic conditions. That's a pretty real assumption. assumed that 50% of those patients might be appropriate for this program and or would consent to the program. And then we assumed that in any given month, about probably 75% of those patients might meet the service requirements. So having that net distilled number from the number on the left, we then applied to that the reimbursement rate, which today is in 2019 for FQHCs, a little over $67 per patient per month. And that drove for us the potential monthly and annual revenue. But then we had to ask ourselves the one question: what would it cost us to provide these services? And so we made an assumption that we could provide services per the requirements of the program for probably less than $50. And if we could do that, and if we could be efficient in so doing, then this might make sense from a opportunity cost basis. Next slide, please. So I won't spend too much time on this because Kathy did a good job covering this, but we needed to next understand and make sure we were aware of what all the requirements were. And at first blush, when you look at these requirements, they can be a little intimidating, but we had to make sure we understood what they were. Next slide. So these may be two of the most important questions of the whole process. Like a lot of FQHCs, our waiting rooms are typically full and our staff are typically flat out all the time. So do we have the organizational capacity to take on another project? The answer to that question is not always easy. But in this case, we felt that the value for the patients and potential value for our staff and our centers was worth it. So then we had to ask, do we have a senior manager or leader who could sort of shepherd this program through the organization? These are gating questions in my view. And if you can answer yes to them, then, and only then, do you have the opportunity to look a little bit deeper. Next question, next slide, please. And so, peeling back the onion a little further, you think about the challenges that you might face. And it's always better to think about those and understand those beforehand than afterwards. And the common factor is that when it comes to CCM, most FQHCs are not staffed to deliver these type of services. Monthly outreach in a structured manner, having staff to do that to patients between their visits. And nor do most FQHCs have a technology platform that will allow them to meet the documentation and information requirements that CMS states are requirements for this program. So you ask yourself, so how will we meet the need here? How do we get around this? I mean, if we, and I will tell you, I've had 7 different experiences with this over the last 2 years with our 7 different health centers, and the answer was not always the same. But I will say that a good number of our centers came to the decision that they probably needed some help to do this, that they did not have the staff and the technology and the processes and et cetera in place to do this successfully themselves. Next slide, please. So that sort of leads us to this, and this is sort of where you consider the option of doing it yourself and working with an outside partner. And there is no right or wrong answer for every center. If an organization has the staff, the resources, the technology, the leadership, and the structure to do it themselves, by far, you probably should, because this is going to be far more intuitive to you than figuring out how to work with an external partner. However, there are benefits for working with an external partner if you haven't, if you don't have everything you need to do this very well. So I want to make sure that you understand that we did have this sort of dichotomy, and that some of our centers said, yeah, we can do most of this or all of this ourselves, and some of them said, no, we're going to have to get a little more resource to help us with this. Next slide, please. And that last viewpoint led us to developing a 30-question vendor assessment tool that when we looked across the marketplace, we saw that there's a lot of organizations out there that bill themselves as CCM service vendors or service providers or partners or whatever you want to call them. We looked across and we selected what we considered to be the top most experienced providers in this area. And then we sent them that assessment and we asked them to complete it. And that gave us the opportunity for those centers who thinking that they needed the assistance of an outside partner, that gave them the ability to evaluate, on paper anyway, but in an apples to apples comparison, the things that we felt were important. Those were the criteria that we put into this assessment tool. Next slide, please. So all that was what went into our decision process. Now we're going to shift over to how we implemented. Next slide. And ultimately, the way it came out is we had the whole spectrum of implementation models. Everything from completely insourced, doing everything ourselves, to completely outsourced. If you see here by this chart, actually five of our centers chose some level of external partner support. We had one center who hired their own staff, but used an outside organization for software only. Next slide. But regardless of which model, one of the things that's most important, and this is probably familiar to a lot of the people on this call today, is to use a very structured project management approach to implementing this. Because CCM is not a one and done program. CCM is a program that's going to go on indefinitely. So in order to make that happen, use a structured project management approach that involves commitment and timelines and goals. And you can expect from the start of this project until the first time you've completed services and met the requirements for your first billable patient, that's going to be anywhere between 90 and 120 days. Next slide, please. So what to expect? When you roll out CCM, it's typically a two-phase experience for the patient. The first couple of months, these patients are getting familiar with the program and the individual who's outreaching to them and calling them on a monthly basis. And also we're really focusing on creating that, I'll say for many patients, in our case it would be were new care plans, and updating them and populating them with all the current relevant information and getting those approved and reviewed and then distributed back to the patient, because the patient gets a copy of their care plan. And then after that, the patient phases into the ongoing service delivery, which includes all those activities on the right. Next slide, please. One of the things we took very seriously and importantly was if we were going to deliver this program, we wanted to make sure that the eligible patients within our centers knew about it, that this was going to be for them a new health benefit. So we utilized a number of different ways to inform our patients. One of which was a mailing, and this is an example of one of those mailings where we would send out a bilingual single-page flyer that would inform patients and encourage them to reach out to us and ask if they're interested. And then we also did things like within the medical records system and the dashboards that our staff use in the mornings when patients are coming in for their visits, we would have flags set up next to the patients who were eligible for the service but haven't yet enrolled. And that would give us the opportunity to provide those patients with some information about this program and encourage them to speak to their provider. Next slide, please. This is just a list of the activities that typically take place in the monthly outreach that happens with our patients. And we've had great success and have seen great value come back to us in all of these. And ultimately, this is a closed loop system in that we are notifying the patient's provider of any changes that take place, and there are some significant changes that take place during those interims between the regularly scheduled visits. Next slide, please. So now on to lessons and results. Next slide. So 5P lessons for us. In this and as in most telehealth initiatives, we need buy-in. We need buy-in from the providers and really any of the staff who are going to have the opportunity to interact with any of the patients who may be eligible for this service. People must understand the value of the program and why we're doing it, and that's critical as a first step. I'd say project management, I've already talked a little bit about that. That's critical for a good launch to the program. If you're going to do this program yourselves, then make sure that you dedicate staff to it. Working with an external provider, an external partner is probably going to have staff that they will dedicate to this for you. But this is not something you can just layer on and hope that someone will have a few minutes to execute the requirements of this program in their free time, because it'll never happen. I would also say start small, and this is also a common project skill or learnings. Begin at one site with a manageable cohort of patients, and then adjust your process. And set goals, monthly, quarterly, and manage to them. I will tell you, even today, 18 months after our first center has implemented CCM, we're still managing to goals. Next slide, please. So here are our results today. After 18 months ago, beginning with a small group of patients in one center, today we have 7 FQHCs with over 2,500 patients receiving these services. We've got awesome stories back from the care managers and even the patients about how this service has benefited them. The things that happen in the interims between their scheduled visits are just incredible opportunities to make slight improvements and maybe in some cases make big improvements in how that patient's care continuum goes on. I will point to one small point here. We noticed in one group of patients where we took 700 patients who've been in the program for 6 months or longer, and we've actually noticed that their PCP visits have increased. And we think that's a good thing, because if they're seeing us, they're probably not getting care in more expensive venues. So we're continuing to start to measure outcomes in that regard. And lastly, as we look ahead to what we'll call phase 2 or the future holds for CCM with us, these are just some of the ways that we believe CCM can help us achieve our goals. But I will tell you, there's no shortage of opportunities for this service where you're outreaching to some of your sickest chronically ill patients in between their visits. There's no shortage of opportunities to make a meaningful difference. And so with that, I'll wrap up. Next slide. And my contact information is here, and I think we're ready to open it up for questions.
Yes. Thank you, Richard. Thank you to all our presenters. That was a great job there. I will now go through the questions. I can hear a little bit of feedback, so if you're not talking, if you could just mute your microphone, that probably will help with the feedback. So, first question is from Dory. We are an FQHC located in a rural area. We hope to have a nurse practitioner in one rural clinic able to see patients in another rural clinic without the travel normally involved. Only a medical assistant will be with the patient. We understand we cannot bill Medicare and Medicaid out of usual PPS rate and be paid. Can you comment on PPS payment via telehealth?
I think in our area, again, Medicaid's been really eager to work with us on caring for those patients. They are actually paying us as a distance site and paying for those services. So I would think in Virginia, we probably are able to do that. Again, you have to go back to whatever your state policies and your state regs say, how well your Medicaid program is working with you in that state. But I would look on a state level first.
The next question, for end-stage renal disease, can I do CCM as a nephrologist?
It's my understanding that CCM is not permitted for ESRD. I will have to research that. We do not have any patients in that category on our program, as I'm aware, but I can get some additional information on that.
Yeah, I know that under the CCM codes, it has to be a FQHC provider, as in like a primary care provider that initiates and manages the patient under the CCM codes, but I don't know about the nephrologist visits for ESRD.
This question is directed at Howard. Do you charge separately for synchronous and asynchronous visits?
I didn't hear the question.
It's do you charge separately for synchronous and asynchronous visits?
Yeah, again, based on state policy, again, they mandate that they will pay us, at the Medicaid rate for anything that's the live video feed, video and audio feed. They may pay a little separately or differently based on some of the store and forward type things, but again, we've been getting pretty decent payment. I think it's comparable to what we would be getting, if we were doing it here on site anyway. And we've really gotten some good reimbursement. We've actually gotten some good pricing on doing things like the digital retinopathy screening. I know a couple of years ago from here, they went to some conference and came back. They were all excited about this new camera and the capabilities it had to do that. And I always protect our partnerships, the people we deal with, and they ask if, well, can we still use UVA and their ophthalmology department do that? And they said, we don't know. So when they called back, they said, no. Well, it turned out the salesman had told them there's a $75 reimbursement on doing the professional and technical component of that. And there wasn't. It's the same rate that we got for doing it anyway. So do your due diligence on checking out to see what your reimbursement is before you jump into something like that.
Thank you. This next question is for Richard. Do you have staff available / monitoring 24/7, 360 days?
So if I heard the question correctly, do we have staff 24/7? We meet the CMS requirement for having access to the clinical care team 24/7. That's sort of a gating criteria to provide this service. So all of our centers offer that to our patients.
All right. I think this may be for Kathy. Who would we bill these services to for Medicaid? As an FQHC, we usually bill Part A for DPS, right?
Is that a question related to CCM in general?
I believe so, yes.
So I didn't go into the detail on how FQHCs bill CCM, but you use the G0511 or G0512 if it's behavioral health. So the G0511 code basically substitutes for all those other codes that are allowable, and the rates are set based on complex CCM as well as regular CCM, so 30-minute, 60-minute, or the general behavioral health.
What kind of platforms are used to track end user participation, billing, surveys?
Yeah, I did not get that question. Could you repeat that question? I'm not sure who it's for.
So I think it's for probably either you or Howard. What kind of platforms are used to track end user participation, billing, surveys?
Ours typically get filed through our EMR. You use the same E&M codes for doing any type of telehealth visit, but you do flag those particularly by there's usually modifiers that go on for to identify it as a telehealth or telemedicine type visit. And so we're able to pull that information out of our system as far as tracking and keeping our numbers and UDS reporting. But we also do our billing through our EMR system, and that's eClinicalWorks for most of the community health centers in Virginia.
So I can just add a point with respect to CCM. Our centers have integrated the process of documenting the time and recording activities for the various participants who are providing services, so that they don't have to work in two separate systems per se. So one of the points here is to try to keep it as simple and intuitive as possible. So that's what we've done.
Thank you. We have a question. Can CCM be done for post-transplant patients who need continuous monitoring?
I heard part of that. I did not hear the last half of that question.
Can CCM be done for post-transplant patients who need continuous monitoring?
I believe so. I will caveat that with this though. If the patient is receiving home health services, which is not uncommon for a post-transplant patient, then you cannot provide CCM in addition to that.
Okay. The next question is, what type of staff can do CCM visits?
So CCM is provided, the ongoing services of CCM are provided typically under the designation of general supervision. So any member of the clinical care team can provide CCM services as long as they're doing so, and here's the caveat that comes up often when we're talking about telehealth and the federal government, is that the individual has to be working within their state scope of I'll call it certification or license in providing those services. So again, any member of the clinical care team and working within their scope of license, I'll call it, as designated or outlined by their particular state.
This is probably for both Richard and Howard, but Kathy have some answers to this too, or to respond. How much does the equipment cost to start a telehealth program?
We've just bought several of the new units, and again, they were less than $12,000 for the camera and the cart that starts that out.
I guess I would defer to Howard, because Howard has done a lot more, I believe, with technology-enabled telehealth than we have. However, I would say the costs depend on what the services that you're going to provide and how you're going to provide it.
Yeah, I would echo what Richard said. I think it really will depend on what your need is, what you're trying to accomplish, and that cost can really vary depending on peripheral devices and quality of camera that you need, and how much of the room and how much control you need of the camera from the far side. So I would say, determine your need first and then talk about what equipment is needed.
And I will sort of follow up on Kathy's comment if I can. Even within that, there's a range. So let's look at teleretinopathy, a program that Howard's doing and a program that we're doing in our centers as well. You can find really good equipment from anywhere from $25,000 to $5,000. So it really, really depends.
Okay, this one is for Howard. How did you get Nutrisystem and glucose test strips and meters at no cost?
Dr. Santon has actually done most all of that. He's not beyond asking people for a lot of things. he got the meals through Nutrisystem. He's worked out some deal with the company in regard to the meters. The meters are about $650 each, but he's come up with enough funding to be able to do that. I know even at one point in time he was looking for peripheral artery disease. It was a device that actually attached to the wrist and to the ankles and measured the level of blood flow that went through that. So essentially looking for those patients that needed surgery through a cardiologist and things. And his ask was for somebody to cover the equipment as well as the interpretations and things on doing that for a 2-year period. So he is really amazing at finding that kind of stuff.
So we are at the hour. I want to be mindful of the speaker's time. We do have a handful of questions left. I just want to check in to see if you're able to stay on for perhaps another 10 minutes.
That'd be fine with me.
I can certainly do that.
Okay.
All right, great. Next question is actually for you, Richard. Can we receive the Excel spreadsheet example in a spreadsheet? I think this was something that was in one of your slides in one of the training. What you might go and do or what the cost was. I think that's what this question is referring to.
I'm sorry, I'm having a hard time hearing your questions. Can you just repeat that, please?
Sure, and I apologize for that. So if the question is, can we receive the Excel spreadsheet example that was in your PowerPoint? I think if they're referring to one of your slides, you had done some sort of cost analysis that was towards the beginning.
Sure, I'm happy to share this information. I mean, if we can help others get through some of the confusion around this program, glad to. So I'm not sure. The individual could reach out to me with my contact information here, or these slides can certainly be shared. If they actually want the spreadsheet itself, I can certainly do that.
Yeah, Richard, if you want to just send us the spreadsheet, we'll link it onto the website so people can just download the slides, look at the video, and also any other type of handouts that any of the speakers wish to share. So
happy to do that.
Terrific. Next question. Well, actually, it's a compliment to all you. So hats off to all the presenters. So let's see. Next question.
Thank you.
Which patients can we assure a zero copay for CCM intervention? Medicare Advantage for sure, right? Also Medicare with a Medicaid secondary, any others?
Yeah, so that's a great question. So CMS back in 2017 clarified this, that certainly they do not have the opportunity to waive copays for this type of service. So patients can be responsible for a copay, and in today's reimbursement of $67, that 20% is probably around $13, which could be an obstacle. But what we have found is that the majority of our patients, the majority of our Medicare patients who are eligible for this program happen to either be Medicare, Medicaid, or to have a supplemental policy. In both cases, there's typically reimbursement for the copay. I know for sure in the incidence of Medicare, Medicaid, or dual eligibles, those patients have no additional financial responsibility. We are fortunate in that we have a good number of those patients. So again, this goes back to one of those early slides. Look at your patient mix and see what that looks like, and you can kind of get a sense of what the exposure to copay is going to be.
And just one thing to add, even CMS does not allow you to waive the copay, but they do allow you to offer financial assistance for patients who can qualify. So that is, if you have patients who can't, who really need this service but cannot afford the copay, you can make other arrangements for providing financial assistance to them.
That is correct. Thank you.
This question is for Howard. Howard share what application or program he is using for diabetes monitoring?
That was that TailCare meter, I think, is the one that Dr. Santon's using. And I think he mentioned the one in there that does the algorithm for, what they do for the insulin regimen. So again, that's in that slide. It's called a TailCare meter. I couldn't particularly tell you the model and number of that type stuff, but just what we get from him in regard to what he's using.
This question is for Richard. How much staff contributed to the implementation within 90 to 120 days?
That's an interesting question. In most of my centers, the implementation process involved a team, an operational, a clinical lead, and the staff who would actually be setting up the program, whether that's internal staff or external partner staff. I will say in parallel, there's a sequence of training sessions that you will want to have with your providers and with your staff, all the way down to the front desk staff, to make sure that everyone who will play a part in rolling this out and making this program available to patients has an understanding of what it is. So I would say though, the core group in most of my centers was probably 4 or 5 people who were meeting on a weekly basis to push the program forward. And then there were other people in the periphery depending on what the tasks were to be done.
Richard, there are a couple of requests for other documents that you had mentioned. They were asking if you could share your 30 vendor questions. That was on slide 10. And somebody is also asking vendor evaluation document. I'm not quite sure if that's a different document, but those were 2 requests that are in. And then,
I think those seem to sound like the same documents, so I'll be happy to share that.
Do your managed care plans pay for CPM outside of capitation?
So we don't have a lot of capitation here. In fact, we have almost none. So we have some managed Medicare, and most of the plans, I'm just thinking as I'm answering this question, most of our plans have provided reimbursement for CCM. It varies. It's not exactly mirroring the CMS rate of $67, but for the most part, and I think there's 1 or 2 plans, and I don't off the top of my head because we have 7 different centers, I don't recall exactly which ones are not paying for it, but most are.
Okay. Do provider visits count toward monthly 20 minutes for CCM?
The answer to that is no. If it's a face-to-face visit, that does not count as services provided in a non-face-to-face manner.
If TCM services are performed in the same month as a submitted CCM service, does the CCM charge just get dropped, or does the program have to track? Just trying to figure out how careful the CCM staff has to be about looking for and tracking TCM services that may have occurred.
Okay, so again, I apologize, but I couldn't quite hear what we're asking. I understand CCM being billed in a month, and what is the other service potentially billed in the same month?
TCM. T like Tom, CM.
That's transitional care management.
Oh, okay, okay. Yeah. Can you bill those in the same month? If they were done at different times, yes, I believe you can.
Okay. Let's see what else is here. Can a specialty service like urology initiate this for their patients?
No, it goes back to who the initiating provider is, and it has to be under the primary care provider.
That is correct.
This question is for Richard. Do we bill Medicare Part A, where FQHC usually bill for office visits, or do we bill Part B?
The CCM, and that's an interesting question. CCM is billed on the same claim that you could be billing a patient a regular face-to-face visit on. So I would assume you're billing it under Part A.
It's the last question. Richard, what is the ratio of CCM patients versus nurses you have in your program?
So I think this speaks to, and I'll try to answer it in this context, how many patients can a nurse who is providing CCM have in her panel to be effective? And that's a good question. We typically say ranges between 150 and 250 patients, and that's a pretty broad range. And why do I answer it in that manner? Because it depends on the clinical condition of those patients. If you have a lot of patients with a lot of who are very, very sick, let's just put it that way, you may spend more than 20 minutes on those patients, and you may not be able to manage more than 150 or 160 patients effectively. However, if the patient's conditions are not quite as severe, your requirements may be a little less per patient. Still, they're probably going to be more than 20 minutes, as we found, significantly more than 20 minutes for most patients per month. But that would enable you to have more patients in your panel. But again, I would say that range is somewhere between 250 at the very high end and 150 at the low end.
We do have one more question. It's kind of general. How does telehealth work with cancer?
For cancer patients?
Yes.
Typically, we can do some of our initial consults with University of Virginia. We actually do. University of Virginia does a lot of things cancer related. I actually serve on a UVA Cancer Center Without Walls advisory board that, they have mobile mammography, they do colposcopy, a number of different procedures that are pretty much they do from a distant site and gets transferred back to UVA. So they're doing some things, again, prevention-wise of trainings and things that can be tied through your local patient education type programs. But any number of things that, again, a big institution like that can do.
Yeah, I can add that, there's the host of services is pretty much up to your imagination, but a lot of the more common things in terms of cancer care are things like telegenetics, allowing patients to participate in clinical trials that they normally would not be able to without some kind of monitoring, and being able to connect with, the facilities that are offering those services, as well as just monitoring of infusion services, sometimes connected to home health. So a lot of those types of things are done on the cancer care end.
One more question did come in. How are services billed when the distant site is an FQHC?
again, for Medicaid and for most of our commercial carriers, you use the same E&M codes that you use for pretty much any office visit or whatever. There are modifying codes that go on to identify it as being, telemedicine or telehealth related. And, Medicare is the one that we really can't bill as a distance site. The only thing we collect is the originating site fee, which probably is around $28 at this point in time.
That was the last of our questions. Every other comment is just high praise for all three speakers. So thank you very much for taking time out to do this webinar. Thank you everyone who attended. The contact information for our speakers is on the slide in front of you. Also in front of you is more information on this webinar series where you can go to a link to subscribe and get more information on upcoming webinars. We also ask that you fill out our survey there to let us know how we did and what feedback that you wish to provide to us. There are a lot of questions about this webinar. It has been recorded. We will post a recording. It will be made publicly available, as well as the slides for speaker permission and any other accompanying documents that you have requested today. So thank you again for everyone for attending. We went a little bit over, but thank you very much for our terrific speakers. I hope everyone has a great day.
Thank you. Have a great day, everyone.
Thanks all.
Thank you.